Thanks everyone for joining. I hope this will be interesting to people. For many of you, it will be very much a recap of things you know very, very well. Hopefully for some of you, there's some novelty in there as well. But hopefully the recap will be interesting too. So I thought it would be nice just to go through some very basic things about clinical phenotypes, a little bit about treatments and how I see those having taught us lots about the patients, and then a little bit about the translational science, just to show some examples. And when I was thinking about how to put together the talk, I thought to myself, well, when did I first get interested in these diseases? And the answer is 2006. And I was a resident working in London, and I was sort of super interested, as many of us were, I think, at that stage, in many different aspects of neurology. So this patient really, really got my attention. So this was a 69-year-old female who, over just about a month, really looked like the archetypal bilateral hippocampalectomy patient. We'd go into the room, we'd talk to her, and she wouldn't remember what we were saying a minute later. And it was really striking for us as, I think, as junior doctors trying to sort of establish an understanding of patient phenotypes. And this patient looked just like HM, you know, the bilateral hippocampalectomy patient, the classic neuropsychological case who's been used in I don't know how many studies over the years. But in addition to that profound anterograde amnesia, this patient had some jerks, and I remember them very, very well, and people being unable to give them a name. So that was really something that sticks in my mind. And she also had numbness and pain in her hands and her feet. And I will confess that I was at Queen Square at this time. And Queen Square, the home of British neurology, certainly perhaps world neurology. And I think it's fair to say nobody really knew what was going on with this patient. I was struck by that. You know, I was 2 years out of medical school. I was completely struck by the fact that none of the greats of British neurology knew what was going on with this patient. So there was even talk, I remember there were even conversations about, is this a new disease? This is something we haven't seen before. So she really captured a lot of people's brain power. And unfortunately, she was going downhill quickly. So there wasn't too much time to do something that neurologists are sometimes culpable of, which is procrastinate. This patient needed serious consideration of treatments. Her CSF and her MRI were pretty normal, so there was no real clue there. And I want you to remember those two things, please, as we go forwards. And her EEG confirmed that she had a moderate encephalopathy, essentially. So there was slowing on her EEG. And so there was deliberation over what to do next. And I remember it really well. There were 3 or 4 people getting together, 3 or 4 consultants getting together on a ward round, asking each other's opinion. There were lots of juniors around, and no one could quite agree. And one of them said, look, one of my adages, and this patient was going downhill really quickly. She was jerking all the time, and she had this profound memory loss. And there was concern about her mortality, really. There was concern she was going downhill enough to need to go to intensive care. And then, of course, there's a mortality associated with that. So I remember one of my consultants at the time said something along the lines of, well, look, one of my old mentors taught me never to let a patient die without giving them a course of steroids. So steroids were given. And it really was very empirical. It was very much, we don't know what's going on here at all. This patient gets steroids. And they made some improvements. It wasn't dramatic, but it was very clear to most of us. And then because she made some improvements on steroids, she was given plasma exchange. And more improvements were seen as an inpatient. And she got home pretty quickly after this point where half of the UK's elite neurologists were unable to make a clinical diagnosis. And so she captured my imagination, really, and for 2 reasons. One, because I thought it was really cool to have multiple different phenomenologies in any one patient. She had a seizure/movement disorder-like problem. She had a classic cognitive problem. She probably had a peripheral nerve problem. And I think many of us couldn't choose which subspecialty to go into. So you kind of didn't need to choose in this patient. And also, and this is the picture you get if you type into Google, patient getting better or patient improving. So she improved, and that was super satisfying. And at this time, I'd been slightly put off many neurological disciplines because the patients couldn't be treated. So these were two reasons that I went into autoimmune neurology. And then this result came back, and this was 2006, of course. And this result came back. So this patient had a VGKC antibody up in the 2,500s when their cutoff from healthy controls and other neurological disease was around 100. So a real dramatic elevation in this antibody. And so this antibody was discovered in Oxford. And so I took a drive, which by US standards is pretty minimal, an hour and 20 minutes, from central London all the way through to Oxford. And I got involved in a PhD there with Angela Vincent, and I was tasked with showing that patients' antibodies, how patients' antibodies bind the potassium channel. And as many of you will know, they turned out not to. We found that they bound to Caspr2 and LGI1 in particular, and that these two proteins were closely associated with the channel, but per se were not the channel. So there was a lot of change in the field around that time in terms of thinking about autoantigenic targets. What do they mean? How do they relate to clinical syndromes? And all in all, we began to define the syndromes by the antibody. And this gave us a great chance to really hone the phenotype much more closely than the potassium channel antibody allowed us to. So we found that these patients were almost never below the age of 50 or 40. They were peaking at a median of about 60 or 70. I know of one patient who was in their 3 figures, and they were male more than female, which was of course unusual for an antibody-mediated or any autoimmune illness. And there were very few tumor cases, which defied some of the previous rules of neurology, because of course, apart from NMO at this time, almost all diseases associated with antibodies were paraneoplastic. They did eventually evolve to have this scan over a few weeks in hospital. And so this became like the prototypical scan almost for this illness. And these patients we now know have lots of seizures. I won't go into each symptom in detail, but they have amnesia, disorientation, which I think fits with this localization, as do seizures. And they also showed emotionality, by which I mean, I sometimes refer to this as Disney syndrome in our patients. These are men in their 50s, 60s, and 70s, and they're sitting with their children or their grandchildren, and they're the ones that are crying over Aladdin's misfortune. So this is something that I've recognized in many of these people and is a very characteristic feature. They have personality changes, behavioral changes, and these are understated, I think, and can be very troublesome for the patients, and also sleep disturbances, especially in the acute phase. And of course, they have this serum hyponatremia, which remains a characteristic sign, although is of course highly non-specific. And it's one of the reasons I really, in general, don't like diagnostic criteria. It's very hard to create diagnostic criteria to fit these patients, because if you look at current diagnostic criteria for AE, these patients don't fit many of them. So they don't tend to have a truly subacute onset in about 50%, by which is defined rapid progression of less than 3 months. Definitely many of my patients present at 4, 5, 6, and further months. Very few have focal CNS findings. Nearly all have seizures, de novo seizures. And then there are 2 bits which prompt me to always put this in italics here, this itis. Do they really have inflammation? Well, they don't tend to have a spinal fluid pleocytosis. And I'd say about half of them have MRI features which look like this classical scan. So first of all, I just want to focus on these 2 investigational features, which try to emphasize that I think they do have itis, but it just hasn't been well detected. So the first thing I wanted to highlight was a very recent observation we published, but it's not an observation that's recent. It's an observation that we've made over about 10 years. Through radiology meetings with our neuroradiology colleagues, particularly Finn Sheeran, who's been a great colleague in trying to understand a little bit more about how these scans look distinctive. And so here are some example scans, but what I really want to show you is this figure here, which are the frequencies of these T2 hyperintensities. And the patients with LGI1, and some had Caspr2 antibody encephalitis, my joint 2 favorite illnesses, are shown here in this figure, where the hippocampus and the amygdala complex are really picked out by these illnesses. If you look at infectious disease, infectious encephalitis, it's much more diffuse, as is CJD. So in terms of control groups, we saw a distinction here between autoimmune and viral or neurodegeneration. And looking at that in a bit more detail, in a bit more of a granular way, these are the autoimmune patients in the top bracket, these are the viral patients in the middle one, and then the degenerative ones in the bottom one. You can see that the autoimmune patients have this medial temporal lobe concentration of T2 high signal, and then really it doesn't extend that much further in the majority of cases. Whereas with viral, it extends right out to the temporal poles often and further. It extends well out of the temporal lobe even. Whereas with autoimmune, less so. Yes, we've seen some patients who have basal ganglia. Yes, we've seen the odd case, but it's definitely not the rule. Much more strikingly, it's almost completely clean. I encourage all my juniors never to say never, and never to say always, but in this study at least, they never had diffusion restriction, which is quite striking, I think. And whereas, of course, the viral and the neurodegenerative cases typically did. And contrast enhancement was also very rare in these cases, whereas it was common in the viral cases. And so from a scan done in A&E, done in ER, I should say with my new American medical knowledge, these patients can be distinguished pretty well just with these features, this restriction, and I shouldn't say that, this localization to the medial temporal lobe, diffusion restriction, absence of contrast enhancement. And you get a pretty respectful AUC. So I think it's really worth remembering this as helpful diagnostic features that you can just run on an MRI, which you or I could interpret. And of course, these patients tend to have a CSF, which is pretty acellular. But when you look harder at the CSF count, yes, you get this back when you run it through your routine labs. But actually, if you run flow cytometry, we've begun to see that these patients have bucket loads of CSF B cells. And these are just the B cells. I haven't included any of the other immune cells in this profile. But they can have many, where each dot is one B cell, they can have many B cells in their CSF. And this is LGI1, and this last patient here is Casper2. And I'm going to come back to this in a bit because these three patients taught us a lot about the underlying immunology. And when we made the finding of this serology, this LGI1 antibody, not this VGKC antibody, the phenotype started to close down because a lot of the patients who had VGKC antibodies that probably didn't have an autoimmune illness were excluded. And the phenotype was really narrowed down much more satisfyingly. So this was the kind of set of features we would see when we were reviewing the patients, when we were reviewing their charts. And I spent a long time looking through their case notes and their charts. So this is a 63-year-old police inspector with a background history of 4 weeks, brief episodes lasting less than 10 seconds, jerking of the hemiface and the ipsilateral arm, and then a more sudden deterioration in his memory. So worth remembering the time course. So jerks come first, also the nature of the jerks, right hemiface and right arm. This is a different demographic, of course, a 48-year-old female. And again, right-sided facial twitching, falls, memory problems. And I really like this description where they were witnessed involving the right side of her mouth going into a spasm and being pulled up. And in addition, her fingers would go into a spasm, mimicking a closed bird beak. The attacks would happen at least 7 to 8 times per day. And then it says that, and then essentially she develops a vague sensation in her epigastrium radiating up to her head. So we term these fatiobrachial dystonic seizures, and did so mainly because it was face and arm predominantly involved, or the leg can absolutely be involved. Dystonic because there's this posturing element which was not myoclonic. And to my knowledge so far, every case I've seen, and that includes email cases, had LGI1 antibodies. Here's an example, and I'll just show you this guy. He's young, but arm, face, leg together. And you'll see it's pretty easy to capture these videos because these patients are having these attacks hundreds of times a day. And so you can see this becomes a distinctive phenotype quite quickly. I'll show you this lady as well, because again, the phenotype is distinctive. And she has her events and she can tell me she's just had one. So she remembers them pretty well. You can see there was one triggered by my my research consent form, unfortunately. And she's telling us about them. You just saw another one there, perhaps. So that was a really subtle one, and that is a really characteristic feature of these patients' attacks. They're not the only seizures these patients have. They certainly have other semiologies, and some of the more characteristic ones include paroxysmal dizzy spells, or PDS as they've been called. So these are short-lived episodes of intense dizziness, which tend to occur in the context of other seizures. Piloerection is very common, and in fact, one of the studies I really like was a study which had no autoimmune preconceptions, but just looked at video telemetry cases with piloerection, and they found that all the cases had an autoimmune problem, of which most had LGI1 antibodies. So this is a common finding in the patients, but it's also a specific finding when looking at just the semiology. And then many of these patients describe hot and cold feelings going up and down their body, and they have ictal, tachy, and bradycardias, which I think are certainly, again, not specific, but getting towards specific in this illness. And then many of them have other traditional medial temporal lobe semiologies as well. So the seizures are distinctive. They're there in pretty much every patient. I can remember only one of the 150 odd patients that we've seen so far not having seizures clearly. When you ask the question, they nearly always have seizures. And one of the characteristics of these seizures is they're very frequent. They're happening hourly. And I often think that if you don't see one on a ward round, you have to question your diagnosis. And as we've begun to see these patients more, of course, these were recognized in the context of an encephalitis or an encephalopathy. But as we've begun to see them more and more, we're recognizing that the seizures can happen on their own. So here are patients with faciobrachial dystonic seizures and cognitive impairment, and they tend to have abnormal test results, at least an abnormal test result somewhere, one or two across MRI, EEG, the serum sodium, and the CSF. But when you look at the patients who only have the seizures, who have very minimal or no cognitive impairment, you see that they tend to have normal tests. So this really boils down to being a clinical diagnosis in the end, because the tests don't help you here. And the other reason why these are important is not just because it is a clinical recognition phenomena rather than anything else, but because treatment matters in these patients. So on the y-axis here, the proportion with ongoing seizures, and you'll see this drops by only about 10% on anti-seizure medications alone. The reason there's this big drop off here is because the number of patients down in the analysis is now single figures from 100. And the reason it's single figures is because many of them have responded very well to immunotherapy. So immunotherapy really helps. Anti-seizure medications not so. And in fact, nowadays, I very rarely prescribe my patients anti-seizure medications at all, because on top of not being very helpful, efficacy-wise, they often cause a rash, and that's an almost 30% rate of rash in these patients. And this was an important observation. I remember when one of my patients came in and he'd just been to intensive care for a few days. He went back home, he got better, he came in to see us and told us about this. And he was in intensive care because of Stevens-Johnson syndrome. So these rashes can be really bad as well in these patients. And at the time, the epilepsy community had identified that rashes in this context associate with HLAs. So we were expected to see the same HLAs that they had described in that field, but we didn't. We saw a very different HLA association here. This DRB10701 allele is present in about 95% of the patients with LGI1 antibodies. Of course, it doesn't explain everything, because around a quarter of healthy people also have the same HLA. But it's certainly a striking number to have a disease with an association at that kind of rate. And it, of course, puts you in the zone of immunology, because HLA molecules have a groove in them, which accommodates a peptide, which bind T cells. So it tells us something about the initiation or perpetuation of this response and how it might go on. When you ask the patients more questions, actually the relatives are the best at giving these answers. You see that the seizures usually come before the onset of amnesia. So most 80% of the dots on this graph will be above the x-axis. So 80% of patients have seizures before amnesia, or before, if you like, an encephalopathy. Now, you remember I've told you already that immunotherapy in particular stops the attack. So our question was, does immunotherapy, if given before the onset of amnesia, prevent the cognitive impairment from developing? And it's very, very clear that it did. So if you treat these patients effectively, ineffectively or not at all, they have ongoing seizures, they develop cognitive impairment. When their seizures stop, cognitive impairment doesn't happen. So it's a very neat paradigm by which we can hopefully make a big difference to our patients by spotting these attacks, not prescribing them anti-seizure medications, and giving them immunotherapy, which could even prevent the onset and certainly the worsening of cognitive impairment. So one question is which immunotherapy, of course. IVIG does seem to have an effect in a randomized control trial, but the effect is minimal. You'll see some patients got worse, some patients got pretty dramatically better, others got minimally better. And you'll see that placebo, some patients got better as well. So it's very subtle, the effect, I would say, of IVIG. In fact, in a retrospective analysis, it seems that steroids do more than IVIG with resolution of seizures and cognitive and disability improvements in addition. And interestingly, even though since I've been in the US, everyone says we give these patients rituximab, there isn't much data to support rituximab. So here's the effect of treating people with rituximab at symptom onset, and here's their last follow-up. And you'll see that the distribution of the modified Rankin scores looks pretty similar to the group that was not offered any rituximab. So there is no evidence to my knowledge at the moment that convincingly supports rituximab in this disease, which is quite intriguing for a disease which I think is very, very clearly antibody mediated, but happy to hear devil's advocate views on that. And so these patients do pretty well in the short term, or can do well, but actually I think some of the research studies over inflate how well they do because they use the modified Rankin score as the outcome, where 0, 1, and 2 would be conventionally considered a good recovery. But actually, when you look at these patients in more detail, they have difficulties with frontal assessments, other cognitive testing, mood, and fatigue. Fatigue seems to be the feature which at long-term follow-up correlates best with their quality of life, in fact. So they do have quite substantial residual deficits. And I think there's still a lot of room to go to try and work out why and how we might improve these. So in the second half, that's mainly what I wanted to say about the clinical features of LGI1. Happy to take any questions now or soon. But I wanted to tell you a little bit about the etiology of these diseases. And this is, I guess, our workflow, what we do. We still do patient phenotyping. We're still interested in outcomes. We are still seeing lots of patients who very generously donate their samples for immunology and neuroscience studies. And the main way we're going about this is by characterizing the immunology as a way to make monoclonal antibodies and use those to understand the underlying neuroscience. So just to give you a better feel for this, I thought I'd play a video that we've worked to try and put together. Oh, I'm sorry about that. Let me play that again. If they're sensing systems, I hope you can all hear this, right?
There's no volume for us.
Ah, that's a problem. Okay, let
Still
me
a beautiful
take
video, but yeah, I'm sure with the volume even better.
I think the volume would be more useful. Take my headphones off. I think that's what's doing it. How's that? No, it's not working, is it?
Not yet, no.
There may be a setting, if somebody knows where it is, that you can make sure a video plays audio. I haven't done that before because I rarely show videos. Can anybody assist with that?
It looks like there's a volume at the opposite end of the.
Our immune system learns to protect.
Yes.
It's called B and T cells, which recognize invaders like viruses. Sometimes, if their sensing systems go wrong, these cells can react against parts of our own body and cause disease. Initially, B cells can sense proteins through antibodies attached to their surface as a B cell receptor. To recognize the many bugs in our environments, this receptor needs enormous diversity. This diversity, however, risks accidentally recognizing our body's own or self proteins. So, the immune system has developed highly tuned checkpoints which remove or inactivate self-reactive B or T cells. If these checkpoints fail, self-reactive B and T cells can escape to key immune system organs, like the lymph glands. Once there, with help from T cells, the B cells' receptors are modified to bind self-proteins more strongly. This is how they gain memory. These now strongly self-reactive B cells can access the brain and release their B cell receptors as antibodies. These antibodies bind self-proteins, causing nerve damage or dysfunction. Our aim is to understand how checkpoints go wrong to develop drugs to more precisely treat these autoimmune diseases.
Okay, I hope you guys could hear that and didn't just politely sit through a minute and a half of not being able to hear it. So that's like a summary of the way we're trying to conceptualize what happens in these diseases, whereby I think it's pretty clear that antibody levels are much higher in serum than CSF. So for me, that's most likely that these diseases begin in the periphery and eventually access the CNS somehow. And so thinking about how they might do that, I'm not sure how they get polarized or primed to their antigen. That's a whole different question. But we've begun to study aspects happening in blood, in cervical lymph nodes, and in tumors, which help us understand the peripheral aspects. And then we've begun to study some aspects of central CSF biology to help us understand this trafficking back to the neurons. So I'll just give you a few examples in the LGI1 space where we have been able to take B cells from our patients, differentiate them into antibody secreting cells, and of course then they lose their surface bound B cell receptor. It's now secreted. If it's secreted in the vicinity of this cell, it should bind LGI1. If it's an LGI1 reactive antibody, we should be able to immobilize that set of antibodies around the cell, and you almost get a little halo around the cell of fluorescence. And that then allows you to capture the cell, and you can make monoclonals from each cell. So we made a series of monoclonals against LGI1, and what we showed is that some of them cross-react with each other and cross-block each other. Others don't cross-block each other, and they fall into groups based on this. And we found that these groups have different characteristics. So some of them bind tissue, some of them don't bind tissue. And what we began to realize is that this is because of the fundamental structure of LGI1. So here's LGI1 in red and blue. Here's its N-terminal half, which is the leucine-rich repeat. And then here's the so-called docking domain known as the EPTP domain. And it docks to these proteins called ADAM22 and 23. And so graphically, there are some antibodies there that you saw that don't bind brain tissue. Our hypothesis is that these are antibodies against this docking domain, and they function to prevent LGI1 binding its receptors on both pre- and post-synaptic termini. Whereas the ones you saw binding brain tissue, we think they are binding the leucine-rich repeat, the blue domain, and therefore seeing the docked antigen already on the surface of these of neurons and perhaps other cells. And so we think there are at least two populations of antibodies in these patients that makes them heterogeneous. Getting monoclonal antibodies allows you to overcome one massive criticism in the field. And one question, which is, do the antibodies themselves, are they sufficient for disease? It means that when you're using patient samples, you don't have confounds of other antibodies being present. There are some patients with at least 2 demonstrable antibodies or other antibodies we don't know about yet being present. And so we have begun to inject these into mice, and the mice will have novel object recognition problems. So they will have inability to say to discern left from right, for example, to discern a novel object versus an old object. And electrophysiologically, they also have an impairment of induction of long-term potentiation, which is the black control antibody showing. So they have a failure of behavioral and electrophysiological functions which are consistent with learning and memory. And also my colleague Suki Wright has just published a paper showing that the monoclonals we made directly cause seizures in mice. So they mimic several effects that the patients have. And it makes you think of how they get there, what they're doing once they get there. And we're kind of basing most of our work around this model of peripheral immunizations, which of course is very, very straightforward and is very much like any other illness. So this is B cells emigrate the bone marrow, they jump checkpoints to do so, they keep doing so, they may enter germinal centers in lymph nodes where they can meet with T cells and antigen. They might then produce an IgM response, they might then produce an IgG response and become memory B cells, so have acquired memory, in this case for LGI1, and then they could either sit in circulation or they could go back to the tissue or the bone marrow as long-lived plasma cells. And so one of our questions that we've been interested one of the questions we've been interested in is, do the antibodies get across the blood-brain barrier or do the cells? And if I show you this figure, you've seen it before, grayscaled. Here I'm showing you in color, because now what we've done is we've picked all the B cell receptors and all the ones in yellow or black, we actually recombined them and made them as antibodies, expressed them and asked if they bind LGI1 or not. And you'll see that 80% of the B cells in the CSF of these patients do bind LGI1, and in Caspar-2 patients, the numbers are pretty similar. It's about 60% if you look at these cells that are individual cells. If you look at cells that are 2 or 3 members, it goes up to 80%. And then the number I really love, never thought I'd see, is 100% when you look at these clonally expanded populations. They're always binding the antigen of interest. And if you think about whether this gives us a cool therapeutic opportunity, it may do, because if you took B cells and you said, here are the ones that don't bind the antigen, here are the ones that do, we only want to target in patients the ones that do bind the antigen. In theory, there are some genes which might allow you to do this, and ditto in the antibody secreting cells. There are some therapeutic opportunities which come from these biological observations. So that was the end of the first half, Meg. I hope I'm not over time. I think we started about 10 minutes late. I hope I'm okay for time, but I'm happy to take any questions now or then. This is my daughter's effort yesterday at trying to bake a cake, which had a hybrid between an antibody and something mayo-like. Here's the lab that we've just assimilated in the US, and obviously a fantastic Florida view. And here are my clinical colleagues to say a big thank you to, who are helping us in so many different ways in the clinic.